Thank you very much, Nikhil. Let's get started. I do not have any financial interest to disclose. I guess most of the neuro-ophthalmologists will not have anything to disclose. So basically all of us sitting here can help a lot in most of these patients, because papilledema is basically a systemic disease. You are diagnosing through the eyes, and optic nerve, as you know, it's a very good window to the systemic disease in several forms, and that's the only place where you can look at the vasculature live happening, like venous pulsation or something like that. Somebody can really look at their pulse, and basically we need to find out what's the cause for raised ICP, and whether it is any space occupying lesions, or is it benign intracranial hypertension, or most importantly in every case of bilateral disc edema, I think in any age, because nowadays we have a lot of patients like early myocardial infarction is increasing. Even in an younger patients, you need to think of malignant hypertension or ischemic optic neuropathy. So always check blood pressure in this group of patients. And next, we should understand how can we help as ophthalmologist or a neuro-ophthalmologist help these patients, whether to monitor or in case of, especially in benign intracranial hypertension, they need a lot of help, the neurologist and the neurosurgeon, and probably prognosticate what is going to happen depending upon the stage of the papilledema. We need to. And as you all know, you know the circulation, how the fluid goes from the brain system to the spinal cord and gets absorbed. And this is one of the mechanism what exactly happens, because there is some blockage or some increased production. That's what is happening, and ultimately there is swelling, exoplasmic blockade, and you can see the visible optic disc swelling. That can be early or chronic, or it can be late. And you can see this theories in different textbooks. I'm not going into the details of that. And what can happen is, as ophthalmologist, it can also cause some kind of collateral damage, like sixth nerve palsy. You need to pick up these things. It's not only about the disc. You need to look around and look for any proptosis or any kind of ocular motility abnormality. As you all know, it can also cause sixth nerve palsy. And etiology, as I told you before, it can be increased brain volume. It's the most common. And then skull volume can be less, especially in cases of craniosynostosis. And occasionally you can have choroidal plexus. These are all not very common what you will end up in your practice, but they're all important causes, because even if it is rare, you need to be able to pick it up. And decreased drainage, especially what happens in hydrocephalus. And if you look at this algorithm, basically, as Nikhil told, the first step is you need to find out whether it is a pseudo or a true, and then unilateral or bilateral. Bilateral ocular causes, basically, I think Dr. Virendra Sachdeva is going to cover. And if you find, do an imaging and then rule out mass, and if normal imaging, mostly you need to think about other diseases. And symptom wise, usually pulsatile tinnitus, paresthesia, headache. They will mainly complain of blurred vision in the early stage, unless in this country we have a lot of patients coming in the late stage with poor vision and papilledema. So otherwise, early stage, if you want to pick up, you can see mainly these kind of symptoms. This may not be the final stage. And what to look for? That's basically mechanical, as Nikhil told, that it's basically glaucoma surgeon look for cupping, and we look for filled cup. Filling can be in any form. It can blur the optic nerve margins, optic disc, and you can see also edema around the optic disc. And you can, if it is too much, you can also see retinal and also choroidal folds. And some of these are mainly vascular signs. When there is congestion, there is exudation. So you will see hyperemia of the vessels overlying the disc. You can expect some of the cotton wool spots and peripapillary and parapapillary hemorrhages. And through our disc already it's covered. And along with disc examination, you need to also quickly run through all the cranial nerve system and some important neurological examination. You cannot leave it to neurologist. You need to check from 1 to all the 12 cranial nerves in a quick manner. I'm not saying that you have to do everything what a neurologist does, but you should have a checklist for all the 12 cranial nerves. Corneal sensation and the 7th nerve is one of them. So you can always do it in a simple way in the clinic for all these things. And also ocular motility is definitely an important thing. It can be a typical 6th nerve palsy, or it can be just abduction lag like this. And as Nikhil showed, you can also see most of the residents will have a doubt. If I have a spontaneous venous pulsation, what do you take out of it? So 90% of the people a normal person can have SVP present, but 10% of them still may not have. It doesn't mean that they have some intracranial space occupying lesion. But this SVP you need to take from case to case. What's the finding? What's the thing? You cannot say that, okay, I cannot see SVP, so he has some papilledema. It has got variable things, so you need to take from case to case basis. And these are all the stages I was talking about. This is early. These are all bilateral cases. I am showing you only one disc here, and you can see the early disc edema here. Here everything is established. You can see the NFL opacity and also the folds, and this looks a little tortuous, mainly because of the magnification effect. And typical champagne cork appearance with the chronic papilledema, which is there for a few months. And this is one of the entity you need to think of. Edema may not be so much, but still there will be pallor, which is more than edema, but they will have a combination. And we do have substantial amount of patients coming at this stage. It's not that everybody will come to you with this stage. And this is one of the typical patients referred to me as papilledema. Simple test you can do before taking a fundus photograph, autofluorescence. You can see typical. He has retinal dystrophy. You can see the abnormality RP changes. It can be clinically made out, and also you can see the autofluorescence there. This is one more thing, and you can be sure that this patient doesn't have any other abnormality. It's an exposed drusen there along with retinal dystrophy. And this is one more case, very similar. It's not that all the cases will have abnormality, and you can also use ultrasonography to rule out. Along with that, you can see a typical drusen here. These are all, most of the ophthalmologists setup will have this. You need not send them for imaging in all the situations. And investigations mainly to look for optic nerve dysfunction. In early stage, you may not have all this dysfunction, but in late stage, you can have. And as I told you before, I think I will do the first thing is this. Simple things always is very important, because even if you miss one, the whole thing will go wrong. You will send the patient back saying that imaging is normal, we will conservatively manage. But this is one of the important thing I would say for everybody to do, and then go on from whatever is possible, because there is economical issues here also with the patient care. It's not just that you can order just like that. So, but all the things has to be taken care, and HVF, Humphreys visual field, can help in some of the cases. And if you have a setup, I wouldn't say for a normal general practice, it may not be so much important. But if you have a BICH patient, if you are following them up, and you can do a serial swelling, you can do a OCT and find out what's happening. But it's not mandatory. You have all the clinical skills to say that this disc is flat or edematous. This is absolutely clinical examination, but if you have it, these things can help. And also you can see the around the optic nerve, you can see the swelling because of the BICH. And this is a typical hypertensive retinopathy. He just needs a referral to the physician and management. And with the management, you need to also give them prescription in the form of how don't drop the blood pressure immediately. What they do is they will give a severe dose of mannitol, but that has to be in a phased manner, because if there is severe sudden hypotension, they also can go into from malignant hypertension to ischemic optic neuropathy. That's important message you need to give to the physician when you refer. And MRI, I think most of us have an access. Only thing is the financial issues in some of the situations. This is important because you can pick it up most of the things, and you should be knowing a little bit about interpretation of MRI when you say, but I'm not going into the detail because it's beyond the scope of this presentation. And if you have everything normal, you should not stop there. And MRV, the venography, is most important. Again, we have few cases, I think, in the next talk. And this is one thing which most of the ophthalmologists and even the neurologists, I think I would spend a little time here, because you send for CSF analysis. What they do is, they wouldn't do CSF opening pressure. This is most important than analysis for our point of view. Unless they have meningitis or any other neurological symptom, that's fine. But if you have bilateral disc edema, imaging, MRV, everything is normal, you send for CSF analysis. But you should be very careful to write CSF opening pressure. This is the most crucial information what you want. You may add to this CSF analysis, which can give rise to other things if there is something. But in BICH or intracranial hypertension point of view, CSF opening pressure is the most important thing. And you have lumbar puncture done, but you will not have the manometry measurement. I think this is one more important thing. In terms of management, mostly it's a multidisciplinary, because you need neurosurgeon help or neurologist depending upon the location of the tumor. Only thing is, you will be, as an ophthalmologist, we will be able to help them with the field testing and whether the disc is improving or not. But only where a situation where we can help them further is in intracranial hypertension, where you have medical treatment in the form of carbonic anhydrase inhibitors and surgical. I am not really going into the detail, but I will just give an overview of this. Look at this patient. She came with diplopia and headache. You can obviously see that definite bilateral abduction limitation. You can say that it's a bilateral 6 nerve palsy. She had esotropia of 45 prism diopters. She came quite early. You can look at the disc here. If you look at the magnified view, early to May, I would say that it's established disc edema both sides, and we did MRV as well. And we also referred her to the neurologist. And these are the risk factors you need to look at, especially the yellow ones. They are few of the risk factors you need to ask in the history in idiopathic intracranial hypertension, and some of this associated systemic conditions, because they are also important, and most of them will be written on their face. By looking at them, you can probably order. And there is an entity called pediatric versus adult. There is some difference, especially with the obesity and other factors. Mainly the management is medical in the form of acetazolamide. If they have allergy to this, probably you can switch over to opiramic acid or maybe furosemide. And one of the important thing from our side is they should get frequent renal ultrasound. They have a high risk of nephrolithiasis. So this is one thing you need to keep in mind, along with other advising regarding increase of intake of water and potassium supplements. You need to advise them this as well. And if they have a severe vision loss because of the established thing, to recover vision at the acute phase, you can also give them steroids. Steroid doesn't have a long-term effect. Just to hasten the visual recovery, it may be useful. So, main treatment is reducing the pressure, and other things are repeated lumbar puncture, LP shunt or ONSD. This is a big debate. I wouldn't again go into the detail, and this is the pictorial representation. I think Jyoti has a big series. Probably I don't have time to show the series here. And one of the important thing is you need to be monitoring them for disc edema. I would say that frequent visual field and to look for flattening of the disc is the most important clinical information you can give to the neurologist if he is under the care of neurologist. And this is the same patient. You can see that after the treatment, she just came very early. We started her on medical treatment. You can see the abduction has improved. And this was the disc before, and this is after. You can see that everything is flattened, and she doesn't have any kind of visual deficit, even on the form of visual fields. So, in summary, I would say that papilledema is a sign of systemic disease. Rule out other oculi, because you should not think only about systemic. That talk is covered by Virender, I think. He will give inputs into that. And always, I would say, first rule out malignant hypertension and then imaging. And it's a transdisciplinary. It's not one person's domain. It's a transdisciplinary approach. And it can be life-saving in most of the situation, and also it can be vision-saving. Thank you so much.